Hello viewers, I am Dr. Raviul. I work as a lecturer of pathology in a medical college hospital and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is chronic myeloid leukemia. This is the third lecture of our ongoing leukemia series. In this lecture, we will learn about introduction and definition of chronic myeloid leukemia, the concept of Philadelphia chromosome and its role in pathogenesis of chronic myeloid leukemia. We will also learn about the etiology, incidence, clinical features, phases, laboratory diagnosis, differential diagnosis of this disorder, and towards the end of today's lecture, we will also talk briefly about its treatment. Okay, a lot of topics, so let's begin. First question, what do we mean by chronic myeloid leukemia? Chronic myeloid leukemia, which is also known as chronic myelogenous leukemia, is a myeloproliferative neoplasm. It is characterized by predominant proliferation of granulocytic cells. As we will see, it is a clonal neoplastic disorder of hematopoietic stem cells. And the defining characteristic of this disorder is presence of Philadelphia chromosome and/or BCR-ABL fusion gene in all the neoplastic cells. Now, after watching this slide, you may be asking me, Dr. Rabiul, what do we mean by myeloproliferative neoplasm? What do we mean by clonal neoplastic disorder? And what do we mean by this term, Philadelphia chromosome? And these are all very good questions. So, before moving forward, let's try to answer these things first. Now, what do we mean by myeloproliferative neoplasms? These are clonal neoplastic disorders of pluripotent hematopoietic stem cells, and it is characterized by excessive proliferation of one or more of the myeloid cell lines like granulocytic, erythroid, and megakaryocytic cells. So in this slide we are seeing the World Health Organization classification of myeloproliferative neoplasms. You can see that chronic myeloid leukemia or chronic myelogenous leukemia is listed at the top. However, also note that there are other disorders included in the classification of myeloproliferative neoplasms besides chronic myeloid or chronic myelogenous leukemia. They will include chronic neutrophilic leukemia, chronic eosinophilic leukemia not otherwise specified, primary myelofibrosis, polycythemia vera, essential thrombocythemia, mastocytosis, and myeloproliferative neoplasm unclassified. Now, the reason I am showing you this classification is to say that chronic myeloid leukemia is a myeloproliferative neoplasm, but there are other neoplasms in this myeloproliferative neoplasm group, and that's why I had shown you this classification. So what do we mean by clonal neoplastic disorder? Always remember, the initial development and growth of a neoplasm is dependent on a population of one single type of neoplastic cells descended from one progenitor. Those identical cells from a shared ancestry are referred to as clonal cells. So this slide is showing a simplified diagram that is denoting the steps involved in hematopoiesis. So at the top we can see the multipotent hematopoietic stem cells, and it all begins in those stem cells, and then the multipotent hematopoietic stem cells are differentiated into two lineages. Some of them will differentiate into common myeloid progenitor, while others will differentiate into common lymphoid progenitor. From common myeloid progenitor, we will again get two types of further differentiated cells. They are the megakaryocyte erythroid progenitors and granulocyte macrophage progenitors. Similarly, from the common lymphoid progenitors, we will also get two types of precursor cells. They are precursor T or natural killer cell and precursor B cell. And then we can see that from the megakaryocyte erythroid progenitors, we will ultimately get platelets and red blood cells, and from the granulocyte macrophage progenitors, we will get the granulocytes like neutrophil, basophil, eosinophil, and also monocyte that will be further differentiated to make macrophages. And from the precursor T or natural killer cell, we will get T cells and natural killer cell, and from the precursor B cell we will get B cell. And as we will see, B cells may be further differentiated into plasma cells as well. So how can we define chronic myeloid leukemia? According to World Health Organization definition, chronic myeloid leukemia is established by identification of clone of hematopoietic stem cell that possesses the balanced reciprocal translocation between chromosome 9 and chromosome 22, forming the Philadelphia chromosome. Philadelphia chromosome, which is also written as PH chromosome, is formed by reciprocal translocation between chromosome 22 and chromosome 9. The Abelson gene or ABL that is located on chromosome 9's long arm is translocated to fuse with BCR or breakpoint cluster region gene of chromosome 22. As we can see, the BCR gene is located in the long arm of chromosome 22. Note that Q here denotes long arm and P denotes short arm of a chromosome. So as it is written 22q, so it is denoting the long arm of chromosome 22. The Philadelphia chromosome refers to the shortened chromosome 22, and it was first described by the investigators in Philadelphia. The fusion product so formed is termed Philadelphia chromosome, and it is written as such. And this should be positive for making the diagnosis of chronic myeloid leukemia. So this image is summarizing how Philadelphia chromosome is formed by balanced translocation between chromosome 9 and chromosome 22. So on the top left we can see a normal chromosome 9. It has a short arm that is denoted with P and a long arm that is denoted with Q, and we can also see that in the long arm of this normal chromosome 9, drawn in green color, is the Abelson gene that is labeled as ABL. On the top right we can see a normal chromosome 22. It also has a short arm that is labeled as P, a long arm that is labeled as usually as Q, and in the long arm of this normal chromosome 22, drawn in red color, is the breakpoint cluster region gene that is labeled as BCR. Now what is happening in the bottom two images? We can see that part of the Abelson gene has been translocated from chromosome 9 and it has gone to the long arm of chromosome 22 as shown in the bottom right image. Okay, so we can see that now the Abelson gene that was drawn with green color is fused with the breakpoint cluster region gene of chromosome 22, and they are forming a fusion gene, and this chromosome is called Philadelphia chromosome. Similarly, we can also see that part of chromosome 22 was also translocated to chromosome 9. So no genetic material is lost during this type of translocation, and that's why this is called balanced translocation. Now the site of breakpoint in BCR gene is variable. Therefore, the size of BCR-ABL protein varies from 185 kilodalton to 230 kilodalton. Most patients with typical chronic myeloid leukemia have 210 kilodalton fusion protein. So now that we have talked about Philadelphia chromosome, now let's move on and talk about the pathogenesis of chronic myeloid leukemia. Now this slide is summarizing the pathogenesis of chronic myeloid leukemia when there is formation of BCR-ABL fusion gene due to balanced translocation between chromosome 9 and chromosome 22. This fusion gene will ultimately be translated into BCR-ABL oncoprotein. This oncoprotein will exhibit constitutive kinase activity, and this will lead to excessive proliferation and reduced apoptosis of the neoplastic cells. Also, the ability of these oncoproteins to act as DNA binding protein will be altered, and binding of these oncoproteins to actin microfilaments of the cytoskeleton will be increased. All these things will lead to development of chronic myeloid leukemia. So now that we have talked about the pathogenesis of chronic myeloid leukemia, now let's move on and talk about its etiology or causes. There are no familial associations in chronic myeloid leukemia. The risk of developing this disorder is not increased in monozygotic twins or in the relatives of the patients. No associations exist with exposure to benzene or other toxins, fertilizers, insecticides, or viruses that we had seen in case of acute leukemia. However, exposure to ionizing radiation has increased the risk of chronic myeloid leukemia, which peaks at 5 to 10 years after exposure, and it is dose related. Now, what are the causes of high dose exposure to ionizing radiation? They will include nuclear accidents, radiation treatment for ankylosing spondylitis or cervical cancer, etc. The median time to development of chronic myeloid leukemia among the atomic bomb blast survivors of Hiroshima was 6.3 years. And we also know that in Chernobyl nuclear reactor there was also a nuclear accident. However, the incidence of chronic myeloid leukemia did not increase following the Chernobyl nuclear disaster. Now, what do we mean by these last two bullet points? We can see that only large dose of radiation can cause chronic myeloid leukemia. When there was atomic bomb blast in Hiroshima, the affected individuals were exposed to large dose of radiation, and that's why many of them developed chronic myeloid leukemia. However, in case of the Chernobyl nuclear reactor accident, the dose of radiation was not that high. So now that we have talked about the etiology of chronic myeloid leukemia, now let's move on and talk about its incidence. Regarding incidence, always remember that chronic myeloid leukemia is primarily a disease of adults, but also occurs in children and adolescents. The peak incidence is in the 5th to 6th decades of life. So now that we have talked about the incidence of chronic myeloid leukemia, now let's move on and talk about the clinical features of chronic myeloid leukemia. Regarding clinical features, always remember the onset of chronic myeloid leukemia is insidious. Mild to moderate anemia and hypermetabolism leads to fatigability, weakness, anorexia, that is loss of appetite, and weight loss. In case of splenomegaly, that means enlargement of the spleen, dragging sensation in the abdomen may be felt. In case of splenic infarct, acute onset of left upper quadrant pain may be also present. Now, the three phases of chronic myeloid leukemia are the chronic phase, accelerated phase, and acute blast crisis phase. So let's talk about these three phases one by one. In the chronic phase, the leukemic cells retain the capacity for differentiation and maturation and are largely able to function normally. the disease is responsive to chemotherapy and remains stable for variable period. The duration of this stage is about 3 to 5 years. Moving on to the accelerated phase, during this phase, leukemic cells show increasing loss of differentiation and loss of maturation, increased proliferation, and resistance to chemotherapy. Chronic phase gradually evolves into this accelerated phase in 70% of the cases. And during this phase, the disease becomes more aggressive. Majority of the cases that are in the accelerated phase may progress to acute blast crisis phase within a span of few months. Moving on to the acute blast crisis phase, this occurs when there is transformation to acute leukemia and the disease becomes extremely resistant to chemotherapy. Median survival is 2 to 6 months. About 30% of the patients can progress to this blastic phase without intervening accelerated phase. So now that we have talked about the clinical features, now let's move on and talk about the lab diagnosis of chronic myeloid leukemia. So first, let's talk about the lab diagnosis of the chronic phase. In the peripheral blood examination, we will find anemia that will be mild to moderate, normocytic and normochromic. Total leukocyte count is moderately to markedly raised, and it is commonly more than 100,000. All stages of maturation from myeloblast to segmented neutrophils are present, with peaks of myelocytes and segmented neutrophils. Blast cells are less than 10%. Basophilia is important for diagnosis of chronic myeloid leukemia since basophil in high amount is rarely seen in any other disorder. So, in the chronic phase of chronic myeloid leukemia, we will also see a lot of basophils in the peripheral blood examination as well. So this slide is summarizing all the stages of maturation from myeloblast to segmented neutrophil. So how can we identify a myeloblast? It is about 15 to 20 micrometer in diameter. It will have a round to oval nucleus and small amount of basophilic cytoplasm. And always remember, the nucleus will contain 2 to 5 nucleoli. Moving on to promyelocyte, we can see that it is larger than the myeloblast. So that's a very important thing to know, that it is larger than myeloblast. Also note that in the promyelocyte we can see primary granules, which are also called azurophilic granules, and the nucleus also contains 2 to 5 nucleoli. Moving on to myelocyte, how can we identify myelocyte? Myelocyte is characterized by appearance of secondary or specific granules, and they will also have round to oval eccentrically placed nucleus. Moving on to metamyelocyte, how can we identify metamyelocyte? We can see that the nucleus is kidney shaped or it is indented, and again another identifying feature is that in the cytoplasm it will have both primary as well as secondary granules, just like its previous cell, that was the myelocyte. The next cell in the maturation process is band cell. How can we identify band cell? It is obvious, the nucleus is just like a band and it has fairly constant diameter. And the last stage is segmented neutrophil, and how can we identify segmented neutrophil? It will have 2 to 5 lobes, and they are joined by thin filamentous strands. So these are the lobes, and we can also see the thin filamentous strands. Moving on to bone marrow examination. In the chronic phase of chronic myeloid leukemia, we will see that the cellularity will be hypercellular, myeloid erythroid ratio will be 10 to 1 to 50 to 1. Always remember, normal ratio is 2 to 1 to 4 to 1. Myeloblast will be less than 10%. Megakaryocytes are frequently increased in number and they are typically smaller in size with hypolobated nuclei. In the cytogenetic analysis of bone marrow and peripheral blood, we will see that Philadelphia chromosome is present in more than 95% of the cases. That means in some cases of chronic myeloid leukemia, Philadelphia chromosome cannot be demonstrated by cytogenetic analysis. However, in most such patients, the rearrangement of BCR-ABL gene can be demonstrated by southern blot analysis, fluorescent in situ hybridization, or polymerase chain reaction. Now, according to World Health Organization classification, the accelerated phase is characterized by presence of one or more of the following features. Blast cells are 10 to 19% in the peripheral blood film and bone marrow. Peripheral blood basophilia more than or equals to 20%. Persistence of thrombocytopenia, that is unrelated to therapy, or persistence of thrombocytosis, that is not responsive to therapy, progressive splenomegaly and increase in leukocyte count, and cytogenetic evidence of clonal evolution. According to World Health Organization classification, blast crisis phase is characterized by presence of one or more of the following features. Blasts in the peripheral blood film or bone marrow will be more than or equals to 20%. Blast proliferation at site other than the bone marrow. Focal clustering of blasts in the bone marrow. Always remember, blast crisis in chronic myeloid leukemia may be myeloid or lymphoid in nature. So we may see myeloblast or we may see lymphoblast. So now that we have talked about the lab diagnosis of chronic myeloid leukemia, now let's move on and talk about its course and prognosis. Now, chronic phase of chronic myeloid leukemia may run a stable course with a median duration of about 3.5 years. Chronic phase gradually evolves into accelerated phase in 70% of the cases, and in about 30% of the patients, we will see that they can progress to blastic phase without any intervening accelerated phase. Median survival is 2 to 6 months in the blast crisis phase. At diagnosis, prognostic factors associated with shorter duration of survival are older age, large spleen and liver size, increased number of blasts, increased number of basophils, and fibrosis of the bone marrow. The differential diagnosis of chronic myeloid leukemia will include non-neoplastic changes, particularly leukaemoid reaction, other myeloproliferative neoplasms, spatially primary myelofibrosis and essential thrombocythemia, myelodysplastic or myeloproliferative neoplasms, particularly atypical chronic myeloid leukemia and chronic myelomonocytic leukemia, which is written as CMML, myelodysplastic syndrome with deletion of the long arm of chromosome 5, and de novo acute leukemia. So this slide is summarizing the differences between chronic myeloid leukemia and leukaemoid reaction. Regarding clinical features, we can see that in chronic myeloid leukemia, often there is enlargement of the spleen or splenomegaly, whereas in leukaemoid reaction, the clinical features will be according to the underlying cause. Regarding the peripheral blood film white blood cell count, in chronic myeloid leukemia, it is usually more than 100,000 per cubic millimeter, whereas in leukaemoid reaction, it is usually less than 50,000. Now, we had seen that in chronic myeloid leukemia, there are peaks of myelocyte and neutrophil, and such peaks are absent in leukaemoid reaction. On the other hand, toxic granules are absent in chronic myeloid leukemia, but they are present in leukaemoid reaction. Basophilia, eosinophilia, monocytosis, these are seen in chronic myeloid leukemia, and they are usually absent in leukaemoid reaction. In bone marrow examination, we will see trilineage hyperplasia in many cases of chronic myeloid leukemia, and in leukaemoid reaction, we will see myeloid hyperplasia. And the last point is summarizing the genetic analysis. In genetic analysis, in case of chronic myeloid leukemia, we will see presence of Philadelphia chromosome or BCR-ABL gene rearrangement in all the neoplastic cells. However, we won't see such thing in case of leukaemoid reaction. Now, this slide is summarizing the major differences between chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Regarding blood smears, we can see that in chronic myeloid leukemia, all stages of myeloid maturation will be seen, and there will be peaks of myelocytes and segmented neutrophils. In polycythemia vera, the blood smears will be thick due to erythrocytosis. In essential thrombocythemia, there will be thrombocytosis with marked variation in size, and in primary myelofibrosis, we will have leukoerythroblastic reaction. In bone marrow examination, in case of chronic myeloid leukemia, we will see trilineage hyperplasia with granulocytic predominance. In polycythemia vera, there will be also trilineage hyperplasia, but with erythroid predominance. In case of essential thrombocythemia, bone marrow finding will show numerous dispersed, large, and mature hyperlobated megakaryocytes, and in primary myelofibrosis, there will be predominantly granulocytic hyperplasia and highly bizarre megakaryocytes in tight clusters. And regarding the predominant cell line affected, we can see that obviously in chronic myeloid leukemia, that will be the granulocytic cell line. In case of polycythemia vera, that will be the erythroid cell line. In case of essential thrombocythemia, that will be the megakaryocytic cell line, whereas in primary myelofibrosis, that will be granulocytic and megakaryocytic cell lines. And we had already talked about the mutation of chronic myeloid leukemia. There will be BCR-ABL fusion gene, and there will be other types of mutations in the other disorders, as we can see here. Now, before moving on to the treatment of chronic myeloid leukemia, let's talk briefly about this disorder, and this is chronic myelomonocytic leukemia. It is distinct from the chronic myeloid leukemia. This type of disorder is usually presented with anemia and splenomegaly in elderly persons. There is moderate leukocytosis, neutrophils and band forms are increased, and obviously monocyte count is elevated, and that is in excess of 1000 per cubic millimeter. Bone marrow will typically show trilineage dysplasia, and there will be increase in monocytic cells. However, basophilia, Philadelphia chromosome, and BCR-ABL gene rearrangement will be absent. The last topic that we will talk about is regarding the treatment of chronic myeloid leukemia. The treatment of chronic myeloid leukemia was revolutionized in 1998 when imatinib mesylate, a potent and specific inhibitor of tyrosine kinase, became available. So this is the first-line drug. 80% of the patients with chronic myeloid leukemia usually present in chronic phase, and majority of the patients achieve a complete hematologic response at 3 months and complete cytogenetic response at 6, 12, or 24 months. Now, what do we mean by complete hematologic response? It means disappearance of all the signs and symptoms, disappearance of palpable splenomegaly, normalization of the total white blood cell count and platelet count, and no immature cells on differential count. So there should be no myelocytes, promyelocytes, or blasts. And what do we mean by complete cytogenetic response? It means no Philadelphia chromosome positive metaphases. Now, for patients showing suboptimal response, options will include imatinib dose escalation or alternate tyrosine kinase inhibitors like nilotinib and dasatinib. For accelerated phase, dasatinib or nilotinib are recommended, and for the acute blast crisis phase, tyrosine kinase inhibitor therapy either alone or in combination with chemotherapy followed by allogenic hematopoietic transplantation is recommended. So this concludes our lecture on chronic myeloid leukemia. I hope this video was helpful. If you like my videos, do comment, share, subscribe, and let me know. And for my students, I will also recommend you to go through your textbooks to know more. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.